One and all. Very good afternoon to one and all. This is Janet, nurse coordinator from Continental Hospital. I would like to thank each and everyone for giving me this opportunity to take on the topic of nursing care and management of post-surgical patients. So, what do we understand about post-operative patients or post-surgical patients? It is nothing, when we explain in a simple terms, it is nothing but a patient who underwent surgery. After the surgery, a patient can be gone into the ICU or the patient can go into the wards. It depends on the history of the patient over there and depends on what type of surgery. Is it a major or minor type of surgery? And the post-operative treatment is mainly depends upon the level of pain, that is the pain management, and the type of wound care we need to provide to the patient as a nurse. So when we come to the post-operative care, we have certain phases in this to be followed. So there are two phases. Among that, the first phase is immediate phase, that is post-anesthetic. Phase 2 is intermediate phase, that is hospital stay, and the last one is the convalescent after discharge to full recovery. After discharge to full recovery, when I go to the next slides, I will explain you in detail. The first phase, let's look into the first phase, immediate, that is post-anesthetic phase. So it is this phase usually requires the nursing care where the early detection of the complications can be detected by a nurse. A nurse who is assigned to a patient mainly should follow the instructions given by the doctor over there. After the surgery, when the patient goes to the recovery area, it is the nurse who monitors over through the monitoring settings over there. And once the patient is comes to a conscious level, then the patient will be shifted to the wards or can go to ICU. But later, when the patient goes to the ward or ICU, it is very important that a case has to be completely given handover from the recovery nurse to the other nurse, that is called as the SPAR, we call it. So that is shifting the patient from recovery room to the other department. Either it can be a ward or ward setup, or it can be an ICU setup. Then coming to phase 2, we have intermediate phase. In this type of phase, it is nothing but the patients who have been transferred from the immediate phase to the post-operative unit, which is nothing but patient can have less observations over there. Minute observations or the minute things have to be observed, such as, for example, we can take as vital signs. So vital signs have to be monitored to the patient. Once the patient is shifted over there, depending on the various parameters over there. So if the patient is not such in a critical condition, but patient can be monitored every 1 hourly, has to be monitored by the nurse. All the vital parameters have to be monitored. So this phase is also called as step down or progressive care unit. So then comes the convalescent phase. So this is nothing but the period of time where the patient gets discharged completely from the hospital and then goes to the home setup area. So there are some of the parameters where the patient should be stable enough to meet all those criteria, then only the patient can be discharged to the home settings over there. So here, if we look into that, all the parameters should be normal. We have to check the wound site of the patient. Is there any bleeding over there? All the patient parameters like vital signs are normal or not? Is there any pain which has been predominantly increasing? What is the grade of the pain over there? Is it mild or moderate or severe? Such kind of pains we have to look into that. When patient is able to regain, because a patient who underwent a surgery, it is the repair of the part which he has undergone. So we have to see all this criteria, like whether the patient is able to meet all this criteria. After all these things, once a doctor gives a fully statement of yes, the patient can be discharged, then the process of discharge can be start, and then patient can be discharged completely from the hospital setting and can go back to the home. So when a patient is in the ward setup or in the ICU setup, there are some of the parameters we need to daily have a observation on that. We have to daily monitor such kind of parameters. That is why the first important sign is the pain score. So we have to check the what type of pain is patient undergoing over there, whether it is a mild pain or a moderate pain or a severe pain over there. Depending on that, analgesics will be given over there, and the appearance of the wound. How is the wound appearance over there? Is that a healthy wound over there? Is it getting dry over there? Or the wound is any pus discharge formation is there? We have to look into that. Dressing also need to be done depending on the evaluation of what the doctor says over there. And hydration. How is the hydration? IV fluids have been administered to the patient because the patient has to be on 6 hours of nil per oral. So before surgery and after surgery also for 6 hours they'll be on nil per oral. So we need to follow the hydration by giving IV fluids over there. So how much rate per hour it has to go on, it has to be decided by the doctor itself. Then the other things what we have to get into is whether any suture removal, is there any suture breakdown over there, or is there any pus discharge formation over there, or is there any bleeding which is occurring, heavy bleeding is occurring or what. Then once the patient get discharged, the some of the things is we need to educate to the patient also, saying that these are the criteria where we have to look into that. We have to educate the patient when they have to come for review again, so that the sutures will be removed, and what on priority basis we have to look over there. So how much is the duration of time for the suture removal? These are the simple questions where the patient or the attenders keep on asking. So all these inquiries, all the queries which they have has to be enclosed by clearing all their doubts. So usually a post-operative patient usually comes to the OPD after 7 to 14 days. So care of post anesthetic care unit, this is nothing but what are the, as a nurse, what is their important role in taking care of patients over there? What are things they need to have a monitoring over there? First one is when the patient comes to the department or when the patient goes to the ICU or ward, first important thing is initial assessment have to be done, head to foot, that is, and monitors have to be connected to the patient as soon as possible. Do not delay in connecting the equipments, all the parameters which has to be assessed every hourly. For the first hour, we can monitor the patient for 15 minutes. Every 15 minutes have to be monitored. Later, every 1 hour, we have to have a closure of monitoring on all these aspects. ECG monitoring is also essential. Then compare, make sure that as the patient is on nil per oral, there can be chances of patient getting dehydrated or patient. So all these things like we need to cover up by providing the IV fluids adequately. How much ml per hour it has to go on over there. So how many drops per minute has to go on. We have to also check the level of consciousness of patient. So how about level of consciousness? We do follow a neurological scale, that is Glasgow Coma scale also. Sensory perception can be done by a pinch also. And reactivity of the pupils also should be observed, and intake and output, which is very, very essential as a nurse. If the patient passed urine within the 6 hours from the surgery point ended, that is the end of the surgery, from then the 6 hours duration have to be counted to check whether patient has passed urine or not. If they have not passed urine, then it is a critical alert that we need to inform to the consultant over there. We have to make sure if the patient is on any drain, care of drain is very much essential. They can be kinking of the tubings also can happen in such kind of situations, or during shifting the patient, or if the patient turns on the bed also, there can be chances of the drain coming out also. We need to make sure the suture site of the drain is very sutured properly, so that we can have a intact observation on that. And we need to monitor how much every 24 hours according to the doctor's prescription we need to follow when we have to empty the drain. Usually we empty the drain every 24 hours. So every day morning, a nurse is eligible to empty the drain, but she need to count how much is the ml drained out. So that is very important, because every day shows if the duration of the drain, the amount which is drained is being high, the drain will be intact in that same position. Once the drain, the level of the drain is, the fluid which is coming, it has to be low, then only the doctors can decide whether the drain has to be completely removed or disconnected. So coming to some of the complications, system wise, if we see, there are various type of complications which we have to look into that. So coming to the cardiovascular, we have a cardiac history. That's very important. Is there a patient with any cardiac history? Elderly, that is above 60 years of age. Debilitated. This means debilitated is nothing but a person whose age is above 60 years, but he is able to perform his activities under limited circumstances only. For example, a patient is able to get up from the bed. He is able to get up from the bed. He doesn't need such constant care from a medical staff over there. So such kind of patients who are able to do a minimal activities, they come under the category of debilitated category. Critically ill patients, monitoring has to be done. ICU patients, we can take it as an example. Hypotension, uh, hypertension, dysrhythmia, we have to check the rhythms. Is there any deviation over there? Any elevations are being found over there? We have to check into that. And hypokalemia, then VTE. What is VTE? That is venous thromboembolism. That is nothing but a clot in the veins, which is a very serious condition, and the nurses should be alert in such kind of situations. So coming to the neurological problems, there are some of the neurological potential complications includes delirium, so delayed emergence, anxiety, depression, and alcohol withdrawal. So when we comes to the delirium, that is nothing but the restlessness or illusions. These are some of the things which is under the component of delirium. Then anxiety, yes, definitely they will be anxious, the patients. Not only the patients, the attender who is there, or the patients who is taking care of the patient who is there, anxiety. And we as a nurses should be very psychologically supporting the patient over there, so that the anxious level can make the fluctuations of the vital signs also. We need to explain each and every pattern, whatever queries the patient brings into our consideration, clear their doubts so that they can be calm enough, they can be confident, and they can undergo the things of the procedure which is there. Any doubt, we need to be up to the point in explaining and clearing the doubts of the patients. Then let's go to the respiratory complications. So some of the complications can be taken into consideration as obstruction. There can be a chances of airway obstruction can be there. Hypoxemia, so that is nothing but the decreased level of oxygen in the blood. Then hypoventilation, that is where the breathing pattern is very slow or it is shallow. So such kind of things where the requirement of the body needs have to be met. So normal breathing pattern is not found over there. The more risk is tobacco smoking, and any patient with any chronic lung diseases also, and patients who underwent any major surgeries like thoracic airway or any abdominal surgeries, and blockage of airway. And most of the patients, when we see supine position, is actually contraindicated. Do you know what is the reason behind it? One of the main reason is circulation supply has to be there. That is why whenever you see, whenever you observe, there are patients when they are shifted from the recovery room to the ICU or to the wards, we make sure that the patient is in semi-Fowler's position. That is main because when a patient lies down in supine position, the circulation flow from head to foot doesn't happen. That is why the main reason is to put them in semi-Fowler's position. And we also have some of the other complications like pulmonary edema, bronchospasm, atelectasis, and pneumonia. So what is this atelectasis? That is nothing but the complete or partial collapse of the entire lung takes place. That is nothing but the lobes. Then we can also consider some of the complications also, like pain and discomfort. Definitely, pain is the first important criteria where a nurse has to assess it. So actually, when we look into the vital signs, the fifth vital sign is the pain. So we need to know the patient level of pain over there and whether the anxiety, fear has been come down or not. Deep breathing exercise, coughing, ambulation, and diversional therapy is also important for the patients. So when we look into the pain, we have different types of scales which are applicable, which are being used randomly in various organizations. So some of the scales which we are using here is like numerical scales we have, then we have Wong's Baker scales we have. So it depends on how you interact with the patient and know the level of pain over there. Some patients will be very terrible or very irritable by expressing their pain over there. So in such kind of situations, a nurse should be calm enough. She shouldn't get panic over there and make sure the pain analgesics immediately have been administered to the patient on time. Do not delay if the patient is suffering with pain over there. Once the patient comes out of the anesthesia effect, then the pain starts radiating to the high core. That is where the nurses should have a continuous monitoring everyone. That's the reason I told initially every 15 minutes we have to have a monitoring of the vital signs over there. Then another complication is like fever. So in what all circumstances fever can erupt? Is there any wound infection, then respiratory tract infection, UTI, then superficial thrombophlebitis. Septicemia is nothing but the infection or the sepsis over there. And then we go to Clostridium difficile. That is nothing but a bacterial growth which causes in diarrhea. That is the Clostridium difficile. When we look into the deep complications, we have shock, hemorrhage, deep vein thrombosis, bronchospasm, which I've already dealt with it before, pulmonary embolism. All these are more complications when we go depth. Constipation also makes an important. Most of our things we neglect over there is patient. When a patient comes, nausea and vomiting definitely will be there. That can be a side effect because of the medications also. Constipation, a diet. Because of the diet, it depends on how much of intake the patient has taken also. So if there is no intake, there are chances where patient goes into thin pass motion for 3 to 4 days. That can also be one of the complication over there. Then preventive methods, we have deep breathing and coughing exercises. Then early mobilization. So deep breathing and coughing exercises is nothing but you can do sit-ups, okay, push-ups, then you can also do yoga also. And we have like a spirometry exercises which are available where the physiotherapist mostly will be dealing to teach the patient such kind of exercises. And early mobilization is nothing but when at least on the next day or the third day the patient has to get mobilized himself from the bed with the assistance to be provided over there. With the help of some assistance only patient can be mobilized. That is nothing but to regain back his energy. So to regain him and to make him independent, we do this mobilization. Muscular strengthening exercises I've already told before. Then nutrition, adequate nutrition has to be given to the patient like protein rich diet. And after the surgery, definitely blood loss will be there. So iron rich diet, calcium rich diet, and protein rich diet. All these diets have to be explained to the patient so that they can improve their electrolytes imbalance is very important. So there should not be any deviation over there. Pressure source pressure source. When it comes to pressure source, I would like to inform there are cases which are major cases or major patients who have been undergone surgery. They might be a bedridden. So in such kind of cases, a nurse should make sure that turning of the position of the patient is very important. Every second hourly, we need to check the pressure ulcers or pressure sores which are there, pressure points which have to be noted down, and check whether there is any discoloration of the skin over there, so that they can be alert and prevent those pressure sores. Adequate pain control analgesics has to be given, but too much of analgesics also can be a chances of nausea and vomiting will be the side effects of it. So pain control can be done even by mobilization also. So once they start making their muscle strengthening exercises, so this can pain control measures can be implemented over there. Analgesics, for example, we can give like tramadol or ketorol. Such type of analgesics can be administered over there. But the duration, there should be a gap of duration. There shouldn't be a gap. For example, analgesics, whatever we administer to the patient, minimum of 6 hours duration has to be there. Please, we should not administer the medicines just 4 hours. Just because the patient has complained, the pain has not yet relieved, so I need another analgesic. So you need to explain to the patient as a nurse, explain them that there should be a duration of time in order to give the another analgesics. Too many analgesics can also cause nausea also. Then coming to the nursing management, there are some of the aspects where a nurse has to get into that and get involved so that she can take care of the patient in a smooth manner. So first of all, she has to assess the patient. While assessing the patient, need to do a physical examination of the patient over there. Handover of the patient taken from the OT recovery staff to a ICU staff or a ward staff. Make sure that you take a described session or described explanation of the handover, which has to be dealt from everything. The patient history to be monitored is very important over there. Airway patency is very important. We need to maintain that. Cardiovascular, as I told you, the previous complications which are there, all should be monitored in a regular basis over there. So pain and anxiety of the patient has to be relieved so that they can be more comfortable over there. From the gastro point of side, when we look into that, they are, as I told you, nausea and vomiting. These aspects and the suture site also have to be monitored daily. Check whether there any pus formation is done, any discharge is there or to the site of that, any redness is formed or any bleeding is there, fresh bleeding is there. All these things have to be aspected, and encourage them to do the activities in a small frequent manner. That is nothing but allow them. If the patient is unable to get up from the bed, at least make the patient to sit, hold some of the things in his hand, so that is how we encourage the patient to become independent. From a simple to a complex state we go. Monitoring vital signs is very important. Pulse oximeter of the saturation, we need to check the saturation or levels of the patient. Conscious level of consciousness through Glasgow coma scheme has to be monitored. How much is the intake and output? That is very essential as a nurse. If the patient didn't pass urine after 6 hours of surgery, immediately a catheter has to be inserted with the approval of the doctor over there. And sometimes patient who underwent surgery, when shifted to ward or into the recovery room or to the ICU, there are chances of patient getting chills. So in such kind of situations, we should make the patient provide with a warmer also, which can relieve the chills from there. Then the other things I would like to give a main important scenario is like ambulatory surgeries which have the patients undergo. So this is nothing but the phase 2. Intermediate phase which is there, that is the extension of the ambulatory stage where a patient will be continuously monitored for the post-operative care until the time of discharge. So for discharge, when a patient is comfortably, when all are normal, all the parameters which are there are in the limit levels, then the patient is ready to get discharged. He should, and what all criteria we have as a nurse, you have to look into that is when the patient is alert, conscious level, pain score of the patient, vital signs have to be monitored over there. And is there any pus or infection taking place or not? Is there any pus discharge is there? We have to give a detailed description for the dressing, when to be done, and what are the diet patient is restricted to take, or what are the diet the patient can take, because there can be chances of the patient either having a diabetes or hypertensive. In such kind of scenarios, patient dietary restriction will be there. So what kind of diet has to be given to the patient, what diet he can take away, what are the health education aspects we have to deal, we have to explain them in detail. And the medications which have been advised by the doctor, we have to explain the side effects of it. What is the duration of time to take over it? Is the medication to be taken before or after the food, or after the meals? Before or after the meals have to be taken? What is the duration? What are the side effects of it? And in case of anything they find anything going on wrong, maybe giddiness or fever or any redness or pus discharge, immediately they have to return back to the hospital to have a checkup again, so that those aspects can be covered and infection can be prevented. So in what all scenarios the patient, we have to call back the patient. We have to explain the patient in their simple language. If there any redness is found, any swelling, that is inflammation, any tenderness, or is there any pus discharge at the site of surgery, immediately the patient has to come back to the hospital to have a checkup. Delay can make the infection beyond. So instead of that, you have to make them alert, explain them all these complications, all the signs and symptoms, so that they can come and have a review and know what is the further instructions and further treatment has to be provided to the patient. So there are other complications which I have already dealt with, the pulmonary problems which I have already told previously, vascular problems and fluid derangement. So these are other things, the fluid electrolyte imbalance, that is. So there should be a proper, there should not be any imbalance between the fluids. So administration of the fluids, which is their IV fluids, have to be maintained until and unless the doctor advises whether patient can have the meals, whether the patient can have the meals after the surgery. So because we restrict the patient not to have the meals after 6 hours of the surgery, because the patient is still in the anesthesia effect. The patient has to come out of the anesthesia effect. Once the patient comes out of the anesthesia effect, doctors advise usually the patient to give liquid, or you can give a soft diet only. So in such kind of situations, start the patient with soft diet. Do not give the patients for initially itself the water or any juices. So there can be chances of, if we don't know whether the patient might be alert completely out of the anesthesia effect or not. So once you give the soft diet, we will come to know the swallowing therapy of the patients. So we can find out whether they are able to swallow, and from that we can detect whether the other food items has to be distributed to the patient or can be given to the patient. So as I told you, see, the discharge planning usually takes some of the elements we need to consider when you discharge patients. Thorough medical reconciliation has to be done. What are the instructions to be given to the patient? And what is the discharge checklist to be given to the patients? There might be patients who are familiar with the medications, what they take. But due to, for example, as a post-operative patient on any anticoagulants will not be started immediately. It has to be started after 3 or 5 days of duration of time only. So we need to explain to the patient and tell them when they can be started on medications, but this has to be approved by the doctors, not by the nurses. So what all the medications have been listed down by the doctors, these medications we need to explain them and advise them to take the medicines on time. And usually the patients who underwent surgery by the time of discharge, they usually don't come back and have a review or the checkup. So we need to instruct the patients, give them a appropriate health teaching so that they can come back and have a checkup, so that further complications can be prevented. One more aspect I would like to go into, that is external ventricular drain. So this is under the neurological system which is comes over there. So the neurosurgeon which performs this procedure. So this procedure, external ventricular drain which is inserted, this is also known as ventriculostomy or ventricular drain. So this procedure is either done in the ICU setup or it can be done in the operation theater also. See, this is mainly because this procedure is mainly done in aseptic techniques in order to prevent the clot in the brain. So in order to do this, what happens, how do we determine this? How do we come to know is, this shows that there is an elevation of intracranial pressure. So in order to bring it to normal, we do this procedure. This is nothing. So we do this procedure so that the intracranial pressure should come back to the normal level. So as a nurse, what is our role over here? What are we supposed to do over here as a nurse? So a nurse should be in this level of this procedure. A nurse should be there to prescribe the point. She has to monitor the vital signs over there. Then every hourly monitoring has to be done over there, and she has to make sure the osculating is patent, and the dressing, the head dressing which is done over there, whether it is intact in position or not. Because the tubings, there are chances where there can be a chances of kink happening. So in such kind of scenarios, we should make sure the tubings which are there are in intact position or not. This procedure is mainly done in a sterile technique only. So the drains which have been there or should has to be monitored every hourly to check there is there any blockage or leakage over there. And while doing this procedure, the medications which are used are urokinase and the heparin over there. So this is mainly administered in order to prevent the blockage over there. And if for such kind of patients who underwent this procedure, procedure, they need to be lying down in straight position only. They cannot be in a semi-fowler's position. The bed has to be in a supine position only. The bed shouldn't be elevated for such kind of procedure. And the tubings which are there and the monitoring setting which is there, it should be placed exactly to the pinna of the ear. It cannot be in an elevated level. So as a nurse, what is our important role? Again, we come into that is, so it is our responsibility, our role as a nurse, we need to take care of the drain over there. So as I told you, the level of the drain, it has to be exactly near the pinna of ear. So you need to measure at least 7 to 9 centimeters. It has to be there within that level only. And you need to observe the drain every hourly. We have to measure. If a junior nurse is posted over there and the senior nurse is there, so please, we need to make sure that a nurse who is experienced one should educate a junior nurse so that she can be following the prescribed orders which are followed. So for intracranial pressure, we need to make sure that it has to be in the normal limits. So for this procedure, there are some of the complications which we have to make sure that patient doesn't go into such complications, that is bleeding. Mechanical, because mechanical is nothing but is there any obstruction of the tubing or any kinking? And neurologically, we have to monitor the Glasgow coma scale. Continuous monitoring has to be done every hourly. And infection like ventriculitis, this is one of the bacterial growth which can take place. So we need to make sure that patient doesn't go into such kind of infection. So when we come to the pain score, we have different types of pain scores available in every organization. For example, we have numerical scale, or we have numerical scale we have, then we have universal descriptor scales we have. It depends on what kind of variations you show it to the patients. So for example, we also have a universal assessment tool where it shows some of the facial grimaces have been observed. So the patients who are unable to verbalize, or patient because of the pain, unable to vocalize the pain over there, we can show such type of scales to the patients where they can show us at what kind of level they are. I would like to tell you to our nurses especially, if the pain score is 3 and above, you have to immediately act to the patient. You have to immediately administer the medications to the patient. Do not delay in administering the pain analgesics to the patient. Pain score, if the pain score is below 2, you can consider is at moderate pain or mild pain. But you cannot, if the patient is 3 or above 3, the score is, it is severe. So please make sure you have to be alert and inform the consultant, and you have to administer the medications which is being prescribed also. Even if you don't inform to the doctor, the prescribed medications which is there, it is already written in your drug charts. You have to follow that and administer it as soon as possible. Once you administer the medications, make sure after 30 minutes of your administration, please go and have a recheck with the patient how much is the pain score. You need to go and recheck with the patients how much is the pain score. Is the pain is the same level, or pain has been reduced or come back to normal or not. We have to check that. So some of the ALRED, this is nothing but this is one of the scale which we follow after when a patient is in OT recovery area. So these are some of the parameters we have to look into that. So like some of the parameters which we look into this is circulation, consciousness, color, respiration, activity. So these are the 5 components which we have to look into that. So coming to these aspects, I would like to tell you when you're scoring in such kind of situations. For example, so when you take a patient's circulation, we have to make sure that patient's blood circulation, that is blood pressure, how much is that? Is in the normal limit or is it high? If the BP is 110/70, it can be considered as normal. But if the BP is fluctuating to 160/100, that shows BP is in high level. So we need to immediately alert our doctors. This is one of the parameters which we did. When an ALRED score comes between the range of 8 to 10, that means the patient is completely fit to get discharged also. But if the score 7 and below 7 is there, that means there is some deviation which is done, which we have to be alert. The nurses have to be alert and implement it so that the crisis which has been there, it has to be implemented and corrected then and there itself. So these are some of.
Okay. So we'll stop at this point of time because as we are running out of time. So nice presentation, Janet. Before I take up the questions from the chat box, I have few questions from the doctor's point of view. So in a post-surgical ward, ICU, I get few questions like the patient's BP was fine and suddenly the patient's BP drops. And I'll just mention what all the common questions I get. You can answer once. There's the most common question we get, that is the last hour the BP was fine and suddenly your BP comes down to 80/40. So why that happens? And second question is the last hour urine output was around 50 ml per hour and this hour urine output comes down. So what might be the cause for such cases? And somebody who is come post-operatively goes into a hypoglycemia. His sugars come down to 80 or 50 and he becomes altered. This is the third question we get commonly. And then the fourth question is the patient is NBM and he has to take his regular medications. Can we give those medications if the patient is NBM or if the patient is in Ryle's tube? So is the regular medications, those medications can be given during the NPO period? That's my fourth question. And the last question is about anticoagulants. The patient had undergone surgery and when is the time for me to give an anticoagulant like low molecular weight heparin or any heparins and all? So if you can just brief out this in one point, I would be happy.
Coming to the anticoagulants, for this, the duration of time, they can start their anticoagulants after 5 days, not immediately because there are chances of bleeding can take place.
We can give post-surgically 12 hours later or 24 hours later according to the surgical procedure.
Yeah.
Yeah.
But the other aspect of questions which you have asked is
Hypotension.
hypotension. They can be elevation because I feel so they might be elevation or there is a deviation over there in the blood pressure, because patient sometimes, though they are hypertensive or not, they might not declare it, or because of that the medications wouldn't have taken it. Usually for hypertensive patients we prescribe telling them take the tablet and come, but because of people who are like uneducated, they are not aware of such things, I don't think they'll take the medication. So there are chances after post surgery we forget about it, we only deal about the pain analgesics over there. So some of the medications have been not been monitored, then only we come to a consideration that we have to start monitoring on those medications.
Okay. Usually it is the intravascular volumes we need to assess regularly post-operatively, and the fluid management. So accordingly, we have to give fluids that might be the cause of hypertension.
And because of that, only urine output also is one of the cause for that. So until and unless patient is hydrated itself, only they can be a urine output. So if there is no hydration over there, there can be chances of less urine output over there. So in such kind of situations, if there is low output, definitely we have to catheterize the patient over there.
One more special case I would like to ask is about the CABG patients. Okay, most of the post cardiac patients, any special things you would like to assess in a post surgical units in the like CABG or any valves?
We have to monitor the patients, especially ECG. We have to see, and monitoring the vital signs. ECG has to be taken. We have to see is there any deviation also in the rhythms over there, and
the drains have to be seen, because most of the post-operative patients, post-cardiac patients, the drains, the quantity and all those things. I need to get a chest X-ray and look for any pneumothorax post-surgical. Okay, any arrhythmias post-surgical. So these are the things we need to monitor. Okay, let's take up some questions from the chat box. Yeah, this already she has explained. So what are the various pain assessment scores in post-operative patients?
We have a numerical scales, different types of scales which are available is verbal descriptor scale. We have a numerical scales. We also have a behavioral scales which are available, and these are some of the scales which have been used with various organizations also. We've started implementing it, but it depends on ventilator. When a patient is on ventilator also, we have a different type of scale to be followed over there in order to assess the pain score of the patient over there.
The next question, what I can see in the chat box, is how to control sugars in your post-operative patients. Even though he's non-diabetic, most of the patients will have high blood sugars. So, or the first sugar levels will be high. So how do you monitor your blood sugar levels?
We have to check the sugar levels of the patient. Once the patient is out of the recovery area to the ICU or to the ward, we have to check the sugar levels along with the vital signs over there, so that we can know whether the sugars are in the normal limits or not. Once you feel that whether the sugar is 60, then immediately we have to start the patient with 25% of dextrose or 50 ml only. So after 30 minutes, then you monitor and check out whether the sugars, because the patient is on nil per oral. So till then, we need to monitor the sugar levels also. Once the patient starts,
how frequently?
Before meal, before meals, TID, we can monitor the patients. But if the patient started taking the maybe 6 hours of duration is over, and the patient takes the feeds from the night itself, though before having the food, before having the meals, we need to check the sugar levels of the patient. That also will give you a exact limitations whether the patient sugar levels has been crossed beyond or not also. Then once the patient starts having their break, once the patient has break their nil per oral, once they started taking the diet, Then informing to the consultant, we can start the medications also.
Okay. So if the patient's sugar levels are on the higher side, so we need to start some insulin. Okay.
Yeah.
So regular insulin you need to start as an infusion and check hourly initially, and once next second hourly, and maintain the infusion as per your organization chart, which they have their protocols.
Yeah, if the patient is on high sugar levels like 400 or 450, or we need to immediately start the patient on insulin scales. We have low grade, high grade, and regular scales we have in our organization. So we start according to that and monitor every hourly over there, depending on how much is the duration, through the doctor's prescription over there, with what scale we have to follow, and through that, once the sugar comes to 100 or 112, we immediately stop the infusion over there.
Okay, so the next question in the chat box is how to maintain temperature of the patient after coming from operation theater. So usually the theater temperatures are usually low, and once they come out to the PSU, so how do you maintain your temperatures?
In the operation theater, as we know, the temperature of the particular room is very high. When coming to the ICU also, the temperature, we can provide a warmer to the patient. If the patient, there are chances where the patient body cannot accept too much of coldness. So in such kind of situations, we have to provide a warmer to the patient so the temperature level will be in the limited level.
Fine. So these are the questions we can get in chat box as of now. So any further questions, I will be waiting for the questions. So to summarize what Janet has told, so post-operative surgical patients are very important for us, and whatever possibilities, the most important thing is the pain management, as we have already mentioned, the temperature control, okay, maintenance of temperature. So, and these are the main things for the nurses to be careful about, and as nausea and vomiting till they come out of the anesthesia. Okay, so those things have to be taken care. And the most important thing is the counseling part, how you talk to the patient and how you educate them regarding the pain management and the surgical care.
My takeaway message to all the nurses who are listening to this session is, first and foremost important is your vital signs. Please monitor the patient's vital sign after post-surgery. Make sure the intake output is the second important point. Then comes to the dietary pattern of the patient. We have to make the patient educate when the diet they can start their diet. Other thing is the medications. Then infection, prevention of infection. So all these 5 components, if you remember, for a patient who underwent surgery, the patient will be out of the infection, and you have given a good care for the patient, where the patient starts trusting the nurses over there. And any queries of the patient, please try to make sure that you give a correct and apt answer to them, so that if you are not confident of giving the answer, at least tell them that we will let you back once we come to the doctors after doctor when visits the patient over there. So make sure that whatever information we give to the patient, they have to follow. Health education is the last and foremost thing. Kindly give a good health education, or you can explain them in their own language what all aspects they need to follow at home when they are at home, and when they have to come for the further checkup also.
So hope you all enjoyed this session, and thank you very much for giving this opportunity. Okay, thank you, Janet, for a nice presentation.
Thank you, sir.
Thank you,
one and all.